Welcome, everyone, and thank you for joining us today. We all understand that vision is vital to a child's development, academic performance, and overall quality of life. Yet many of the traditional methods used to screen vision in children, especially our youngest patients, don't always catch every concern. That's why today's session is so important. We're going to explore how pairing two distinct screening methods, visual acuity assessments and instrument-based screening, can significantly improve the accuracy and impact of pediatric vision evaluations. This session is designed specifically for pediatricians, family medicine practitioners, and community health providers. We'll walk through the strengths and limitations of each screening method, how using both together creates more comprehensive and equitable care, and practical ways to bring this combined approach into your workflow, including recommended age protocols. By the end of this session, you'll walk away with clear tools and strategies to help identify children at risk for vision problems, and more importantly, how to intervene earlier and more effectively. I'm Eric Ryer, and I serve as the Director of Medical Affairs for Worldwide Medical here at Baxter. My clinical background has shaped my passion for improving patient safety and ensuring that the tools we bring to providers are grounded in real-world clinical relevance. My focus is always on the same goal: improving outcomes, enhancing workflows, and meeting the evolving needs of clinicians and their patients. Today, I'm pleased to lead this informative webinar about pediatric vision care, and even more excited for the insights we'll be sharing with you today. To begin, let's look at why early vision screening is so important. Vision problems are common among children, with 19 million worldwide living with a vision disorder. According to the CDC, only 1 in 3 children in the U.S. have received eye care services before the age of 6. Early detection and treatment of vision problems in childhood is crucial, as 80% of vision orders can be prevented or cured. Catching these issues early is essential not just for academic success, but for a child's overall development and well-being. If we miss these problems early, we risk delayed interventions that could have long-term effects on learning and also social engagement. Major medical organizations like the AAP and AAPOS have clear guidelines. They recommend instrument-based screening starting at 12 months of age. Once a child is around 5 and developmentally ready, we move to the visual acuity tests. This age-based strategy helps ensure we're using the most effective tools at the right developmental stage. In the next 2 slides, let's compare the two methods. Chart-based visual acuity testing is the traditional approach many of us grew up with, but it comes with limitations, especially in younger children. It's a subjective test, which means results depend on the child's responses, and that requires a high level of cooperation. Also, it does not detect ocular misalignment, meaning certain vision issues can go unnoticed. On average, it takes about 2 minutes to administer. Instrument-based vision screening takes a different approach. It's objective, meaning the results don't rely on verbal responses or the child's ability to understand instructions. This makes it ideal for younger children, nonverbal patients, or those with developmental or behavioral challenges. It requires minimal cooperation, just a few seconds of a child looking at a target, so completion rates are much higher. In fact, at age 3, instrument-based screening can achieve around 87% testability, compared to only 39% with charts. It's also fast, typically taking about 30 seconds to perform, and it can detect risk factors for amblyopia, refractive errors, and other issues early before they impact learning and development. While it doesn't replace a full eye exam, instrument-based screening is an invaluable tool for increasing detection rates and ensuring we identify children who need further evaluation. It's important to recognize that both chart-based and instrument-based approaches come with their own limitations. Chart-based screening relies on verbal feedback and cooperation, which can be a challenge with younger children. It's also more prone to false positives and negatives and requires significant time, space, and staff training. These limitations can result in missed cases or unnecessary referrals. While instrument-based screening excels with young children or nonverbal children, it doesn't assess functional vision, meaning how well a child can see and interpret visual information like letters or symbols. It also may miss certain non-refractive or neurological issues, and it becomes less effective once the children are ready for subjective acuity testing. And neither method is a replacement for a comprehensive eye exam. They're both tools for identifying children who may need further evaluation. Understanding these limitations helps us appreciate why pairing both methods gives us the most complete picture of a child's health. While both methods have limitations, they also bring important benefits, and understanding those strengths help us design a more effective screening strategy. Chart-based screening gives us a functional view of how well a child can see. For example, reading letters or identifying symbols. It's especially useful for older children, typically age 5 and up, who can reliably participate. It also doesn't require any special equipment, making it low cost and easy to implement. And it's great for tracking visual acuity over time. Instrument-based screening offers a quick and objective way to assess vision, often in just 30 seconds. It's particularly valuable for younger children or those who may struggle with chart-based tests. These tools are highly effective at identifying refractive errors and risk factors for amblyopia, which much higher screening success rates within the 3 to 5-year-olds. They also tend to boost provider and patient confidence in the results and help reduce unnecessary referrals by around 15%. This is exactly why pairing both methods gives us the best of both worlds, enabling more accurate, developmentally appropriate, and equitable care. So let's examine why pairing both methods matter. Instrument-based screening excels at detecting structural and refractive issues early on, especially in younger children who can't yet cooperate with a wall chart. It's quick, objective, and helps flag issues when interventions can be most effective. As children grow and develop, visual acuity testing becomes essential. It tells us how well they can actually see and function in the real world, something instrument-based tools alone can't capture. Furthermore, over 90% of pediatricians are not doing automated vision screening. By combining both methods, we gain a more complete picture of a child's vision health. It's not only clinically sound, but it also aligns with AAP and AAPOS guidelines, supports equitable screening across age groups, and leads to better overall outcomes. While visual acuity testing is the standard once children reach school age, there are many situations where the well-challenged spot vision screener remains the better choice beyond age 5. For example, if English isn't the child's first language, the spot vision screener helps avoid language barriers that can affect chart-based results. It's also ideal for children who are nonverbal or have limited verbal skills, as it doesn't require a spoken response. For those with developmental delays, cognitive challenges, or attention and other behavioral difficulties, the quick and engaging nature of the spot vision screener can help improve completion rates and accuracy. It's equally useful for children with physical disabilities since it requires minimal cooperation or positioning. And finally, the spot vision screener is an objective follow-up when chart-based screening results are inconclusive or fail to capture the full picture. The spot vision screener was designed to help streamline how we approach pediatric vision screening, making it fast, objective, and easy to implement across any clinical setting. With about 30 seconds per screening, you can gather accurate, automated results and streamline the process and help remove the guesswork, especially in our younger patients. It's particularly effective for ages 3 to 5, where traditional methods often fall short, improving completion rates up to 87% compared to just 39% with the charts. It also reduces unnecessary referrals by around 15%, helping you manage care more efficiently and prioritize patients who truly need follow-up. Instrument-based screeners may generate reimbursement revenue, giving your practice the tools to offer better care without adding complexity to your workflow. It's important to note that coverage is not always guaranteed and must be determined by contacting your payer. On this slide, we have a product overview of the spot vision screener. The camera's handheld, portable device that's designed to help you quickly and easily detect risk factors for amblyopia and other vision issues in patients as young as 6 months old. It delivers results in seconds by capturing an image from a non-invasive 3-foot distance. The fixation target and engaging sounds help keep a child's attention, making the process smooth and stress-free. A bright touchscreen display results right away, showing whether the measurements are within range or if a complete eye exam is recommended. These results are straightforward, easy to interpret, and simple to share with patients or eye care specialists. With the well-challenged Spot Connect app, your staff can order a vision screening directly within the EMR and transfer results back quickly. You can also prepare for busy screening days by importing patient lists into the device through the Spot Connect app, a wireless connection, or even a USB drive. This combination of speed, accuracy, and seamless integration helps make the Spot Vision Screener a practical fit for any pediatric care setting. Next, I'd like to look at some real-world results of how instrument-based screening can make a difference for the workflow in patient care. Tribeca Pediatrics is a physician-owned pediatric group with 44 offices across New York City, Westchester County, and northern New Jersey. In 2022, they transitioned from standard visual acuity charts to the Spot Vision Screener for patients 12 months to 3 years old. The Spot Vision Screener's handheld portable design and small pupil size requirements made it a perfect fit for their practice. Since implementing the SVS, Tribeca Pediatrics has experienced that screenings have been faster, easier to document, and provided more detailed clinical information to share with other providers and referral sites. As Dr. Jessica George, a pediatrician at Tribeca Pediatrics, shares, the Spot Vision Screener is easy to use, picks up vision pathology very easily while still amenable to treatment, and keeps our practice in line with the AAP's recommended standard of care. It is also such a valuable tool for older children who are having trouble with the eye chart, saving time and ensuring an accurate examination. And Dr. Modi adds, the Spot Vision Screener has become an important diagnostic tool in our pediatric practice. It is simple to use, yet an effective screening tool for detection of visual abnormalities in our young patients. Thanks to the team at Tribeca Pediatrics for sharing their insight. So we've covered a lot today, all aimed at strengthening your approach to pediatric vision care and supporting better outcomes for the children and families you serve. Let's take a moment just to recap. Instrument-based screeners like the Spot Vision Screener is designed to help you detect vision issues early when intervention can make the biggest difference in a child's development. Early detection matters. The sooner we identify vision risks, the better outcomes for the child. Instrument-based screening is faster, accurate, and more inclusive, especially for young children. Pairing with visual acuity testing helps ensure you're covering both refractive and functional vision needs. And finally, real-world studies show that this dual approach improves clinical outcomes and streamlines workflow. It's a smart, sustainable way to help enhance vision care in the pediatric setting. So that brings us to the end of today's session. Thank you for joining us, and I hope we're able to provide some insight on how we can improve outcomes to your patients.